So in general, CMS is moving towards interoperability. And really what we're talking about is the approach of decreasing latency and response times within healthcare by leveraging existing technology. So whether that's EDI, APIs like FHIR HL7 calls, how do we get the systems to talk together to coordinate better? And especially within the authorization space where they're heavily focused right now, it's to decrease the amount of time it takes for the health system to receive a response about whether or not a service is authorized. And so within that space, I think there are a lot of infrastructure needs to happen in that time frame in order to adhere to CMS's demands. And that is because we see a lot of variance in both the documentation that is sent to the payer today, as well as the policies that they use to make those determinations. It's not uncommon to see more than one policy being leveraged to make authorization decisions. And of course, no patient, no encounter looks the same. And so they do kind of have to look at it through multiple different lenses. But that's why it's important as we build out the system to convert from written policies to a rules-based engine. And so we have spent a lot of time thinking of how do you break down a medical record into a series of inputs that can be fed into a rules engine, and how do we take existing policies and convert them into something that becomes more machine readable? Because if we can get an EMR to talk directly to a health plan system, then we can get a more immediate response time, ensuring that members get the care that they need, and ensuring that that care occurs timely, right? That ultimately is the goal within the authorization space, is if you do need to receive this service, we want to make sure that you can get it timely and that it's medically necessary. I think it's a pain point for both sides, right? Because if you think about the provider side, of course, they want to receive their care. But today, all of these authorizations that are sent are very frequently done through the use of paper. So a lot of times there might be an intake form. Some of that will give some insight in terms of, do we need to dig into this further? But there's a lot of reading of medical records that's done today on the payer side as well. And that's why we see greater than 72 hours sometimes to approve that authorization, is because it's going through a nurse review and a physician review. I'm a firm believer that for many of those, we can get to that decision in a more automated and streamlined approach because it is within the documentation. So just simply by changing the input method, we can get to that decision and ensure that we're only kind of looking at a sub-select few conditions and not having to manually review every single authorization request that comes in. So I think there's a few different methods. We talked about how there's multiple different intake types. So people are trying to solve this problem through a variety of means, right? So EDI is definitely one approach. Being able to use that tool and include the attachment alone streamlines part of the process. The attachment as well, though, tends to be a PDF, unstructured document data set. That's where, for Trend, what we do is we convert that into data inputs. So we convert those records into FHIR objects. I definitely can see as CMS develops the rules and regulations around the authorization API requests that they were going to move towards a FHIR-based rule system. So that way the EMR doesn't have to send a PDF, that instead they'll be able to send it by leveraging the FHIR HL7 messages. Well, of course, not every EMR system today is built to handle some of the latest technology requests. Some are still moving to a different EMR system. Not everyone's on Epic at the end of the day, and not everyone's on the same version of Epic. So there's going to be infrastructure needs on both sides to ensure that you're prepared to accept the request, that you're going to have to build out that API if you're the health plan side. And on the provider side, are you on the latest and greatest EMR version to really start streamlining and integrating? Now, of course, one of the things that the providers can look for are, those vendor services that are provided through the Epic program. So I definitely will be interested to see what technology is brought into the EMR system to truly create an integrated system. So that way you can request those authorizations directly from your platform. The authorization space that right now we're focused on is centered a lot around level of care, imaging, and so forth. But the impact and where the industry as a whole needs to go in the next decade is expanding to the medications. That's a real pain point for our clients across the board, is those infusion denials. They're very manual. There's hundreds of different rules because of all the different medications that exist. So while this is a good stepping stone, we're looking to see how the market expands to those needs because, again, the number of authorizations in general has ballooned over, the past few years. And it's really not obtainable for a provider to have to remember every single rule, what needs authorization for this health plan or this plan type even, and what are those rules. And so today, expecting a provider to go into the different health systems, look it up before they can make that decision is just not scalable. And that's why we see all the denials that we do, because no one can have them all memorized. So again, building towards a technology solution that is maintaining all of those rules will help improve and let us know when authorization is needed and what ultimately needs to happen for that authorization to be secured. I don't think anyone is, personally maliciously trying to get around authorization. It's just simply there's too many rules out there and there's too much variance across each health plan on what those rules look like. That's one area where we see a lot of denials occurring today. That's something that we help a lot of our partners in working towards appealing. And a lot of times it's just simply because, it's not the preferred drug. So we have to show that pattern and behavior that shows that we did try these other medications before we moved towards this infusion. But that requires being able to look at the patient history, which a lot of times the health system doesn't have that complete picture because care is not always done within a single health system, right? It's a network at the end of the day. It takes a village to help our members. The value-based system model that I'm used to seeing is one where the hospital is willing to take the risk on the patient care. But we all know that people like to pick their doctors, that it's very rare that you're going to keep all your doctors in a single system. And so how do you then get the different doctors to communicate in order to ensure that you can take on that risk of caring for the patient? So it becomes even more important to have a tighter communication system between all the different providers. And in those contracts, right, you're looking at measuring certain comorbidities, making sure that they're being managed. And so if one doctor, let's say you have a cardiologist specialist, but then lots of people have different issues. Maybe you need to see an endocrinologist, right? Maybe you also have diabetes. Your cardiologist may not know, are you taking insulin? Unless they're talking to each other. So again, it's just the need to build out a network, whether it's a set of APIs or fire messages, even CDAs are great in the industry, but just to create that consistency of being able to send it, but then also how do you ingest it and how do you create views that are helpful in making those quick determinations? Because a lot of what happens today is, a patient goes into the hospital, they have an incomplete history at that hospital of what the patient's care looks like, and they're trying to evaluate and make the best decisions for that patient. If we are able to present up front what medications this patient's receiving, if we can create consistency around the diagnosis that they have, then we can create better treatment on the front end for that individual. But half the issue is the fact it lives today in attachments and disparate areas. And if it's not the forefront of the doctor, you can't expect them to take that into consideration as they consider care. Actually, you kind of now see the flip side, right? Because the other part of the CMS mandate, we'll see if it actually gets done in 2027 like they're suggesting, is the payer API to help share data over the past 5 years, right? Because your insurance changes on a yearly basis, and it's really rare that you stick with the same health plan. And so what happens, you switch your health plan, you have a brand new set of people that are now helping you take care of your health, and they don't have any of that context. And so a lot of stuff, especially prescriptions, I'm a stickler on the prescriptions that you're used to receiving, that you already probably went through some hoops for, that information's lost, and now you're back to it all over again. So, creating consistency of care becomes important. We can only do that by sharing data across the industry because we are a lot of different health plans, we're a lot of different health systems. So if we're not focused on communication, if we're not focused on sharing data, we're going to continue to see all the issues that we do see today in the healthcare system: delays in care, denials, confusion, anxiety. So really, that streamlining that process as much as possible is, to me, a very, very important part of the reason why I chose to be within healthcare and technology.